And in order to affect change, we want to work with the youth, because what the youth is doing impacts everything around them, but at the same time, everything around him impacts the youth. So there are some ways that you can try and change the youth's behavior by not addressing the youth themselves, but by working with all those other systems around them. And that brings us to this idea about multi-systemic therapy. So multi-systemic, we're working with all of those different systems. So I don't have a whole lot of time to go into detail. The usual MST training is 5 days, and I was given 40 minutes. So it's going to be a highly compressed version. But basically, MST has the tenets that youth behavior are influenced by their friends, family, and communities, and vice versa. Families themselves are the key to success. By harnessing and working with the families, you can actually get the changes necessary to help that youth long term. That change can happen very quickly. Even though these behaviors have been occurring for 12, 13, 14 years, you can make change in a rapid way to affect change. And that families can live successfully without involvement from all these other systems in their life if the families learn the skills necessary. How is MST different than a lot of other programs? Well, in one way that it utilizes this best practices, and I'll talk about that in a slide or two later. Secondly, there's a high level of accountability with MST, with multiple levels of quality assurance, which I'll also talk about a little bit later. The ecological validity. They are working in the youth's natural home and environment, which is very different than working with a youth or a family in an office. Anyone can hold it together for 40 minutes, an hour. But when you're out in the home and you're seeing what's actually transpiring, and you're out there multiple times, very quickly you don't need to ask them to show me what it's like. You're going to see exactly what it's like. And the changes that you're making are going to work because they're actually getting tested in that real world. As compared to these residential programs where kids learn skills in an isolated event. It's easy to say no to drugs if there are no drugs available. How easy is it to say no to drugs if you go out the street for a bag of weed? Lastly, MST is very focused on not just what we're doing in the immediate when we're working with the family, but how are we helping the family learn the skills that are going to last a lifetime. So you can follow and track how the changes that we're working helping families long term, not just when I'm there propping up the family as that fourth leg of the table. What do we do in order to make this work? MST in its whole, compared to some of these other evidence-based practices, is not a regimented, do this week 1, do this week 2, where you're going to open up a practice book and it's going to tell you first session, do this, second session, do this. Basically, you're going to look at problems and understand why problems make sense to this family and how to address them. And I'll talk about that when we get to the principles. But basically, when we're talking about interventions, MST says if there's evidence to support that these interventions can be used, use them. So we're big supporters of cognitive behavior therapy, parent management training, the pragmatic structural strategic family therapies, medication management when it's warranted. It's not the first thing that we're going to do, but if there's evidence to support that it can be helpful, we'll support and advocate for that if the family's up for it. How is it implemented? You've got one clinician working with between 4 to 6 families at a time. They're part of a team between 2 to 4 clinicians and at least a half-time supervisor. So you've got a supervisor working 20 hours a week just supporting 2 to 4 clinicians. The clinicians are available 24 hours a day, 7 days a week. Why is that important? Because if a family crisis takes place, you don't want them to have to wait till next Thursday for their appointment to tell you what happened. You want to be available to take care of that problem, not only when it happens, but as soon as the parent feels like, uh-oh, I see this is coming. How do I handle this? So by having the clinicians available, you're going to be really ensure that families have the support necessary to make the changes in the home at the time when they most need it. Families are being worked with between 3 to 5 months. As I said, change can happen fairly rapidly, but it can happen because the availability means that you can have multiple sessions in a given week. So you might have 60, 70, 80, 90 hours of contact with a family in a 3 to 5 month period, which is the equivalent of like 2 years of outpatient therapy. And the work is being done in the community, in the home, in the school. You're really working with the people that are important to that youth. MST staff typically deliver all the services. It's not a matter of going in, seeing the problems, and referring this kid to ART because they got anger issues. We're going to refer the parents to family therapy because of this. We want to try and do as much as we can during the duration. The more that programs refer clients out to a variety of other services get more fragmented, and additionally, families don't learn the skills that they can handle things themselves. They learn that other people are going to fix the problems. We want to continue focusing on engagement and alignment. Those are the key parts of not only with the family, but all of the other people that MST works with. All of these systems. Could be the probation officer, could be the school teacher, could be the Little League coach, well not Little League, maybe the high school coach, could be the pastor down the street. MST staff tend to have the clinical lead in making decisions to make sure that we're not working in separate directions, and that there's this highly structured quality assurance supervision piece, which is essential. Because what it does is it helps clinicians from getting too caught up into the crises of the family and make sure that they have a lot of feedback to make sure that they're doing everything possible to ensure good outcomes for the families overall. The easiest way to describe why we do things systemically is looking at this causal model of delinquency. And if we wanted to, we could erase antisocial behavior and put in substance use because the model holds true. Can anyone tell me, what do you think the research identifies as the best predictor of a kid getting in trouble? Parents' behavior or past behavior? I'll take the past behavior, which is actually right. The best predictor of you getting in trouble, have you gotten in trouble before? Makes sense. What's the best predictor of using drugs? I did drugs before, I'm more likely to use drugs again in the future. Unfortunately, there's not a lot that we can do about this prior behavior because we don't have any time machines capable of changing that. What we do know is the best predictor, next best predictor of getting in trouble using drugs is
risk factors.
Risk factors such as
Their environment.
Their environment?
Yeah.
Absolutely. So what we do know is their association with antisocial peers and their environment tends to be a catalyst for the large majority of behaviors. There are some kids that are doing it individually, but for most kids, when they're talking about antisocial behaviors, substance use, they tend to be using in groups, they're getting it somewhere. What leads kids to hang out with negative peers? Yeah, family issues come up, lax parenting, in the school, right? So if we're dealing with issues from the family side, things like lax parenting we talked about. So on the family side, things like low monitoring, low affection, low warmth. If you were living in that household, would you want to be there? No. You end up getting out, going somewhere else. On the school side, if you're not involved in school, or you're not doing well academically, so you're not involved in any of the sports, you're not doing any of the activities, you're doing poorly in school, you tend not to do well, these kids end up skipping. What happens when they skip? The school consequences them by suspending them. Where do they go? They're hanging out at church? No, they end up on the street with all their friends hanging out. And even if they're not looking for trouble, what we find is they have the best of intentions going out, and they always say, trouble found me. So I'm just hanging out, and boy, that sounded like fun. Okay, let's go do it. And all of a sudden, we got arrested. So in order to change it, we need to look at these risk factors. On the family side, the poor monitoring, ineffective discipline, low warmth, high conflict, parental drug use, substance use, mental health issues. They got extinct because they didn't listen to their mommies. On the peer side, the association with drug-using peers, low association with positive, pro-social peers. How am I going to get my parents to stop yelling and tell me what to do? Simple. You have to set limits. You go around allowing a couple adults to run your life. Where do you think that's going to lead? According to them, college, career, and a safe, respectable life. And you're going to stand by and let that happen? So the peers sometimes are not really looking out for your best interest. On the school side, this low achievement, the truancy, low commitment to school. As Calvin says, I'm not going to go to school anymore. Oh, nope, I decided to be a hunter-gatherer when I grow up. I'll be living naked in the tropical forest, subsisting on various drugs and the occasional frog, and spend my free time grooming for lice.